Hello, I'm Dr. Logan, and I'm going to be talking about the situation where we consider radiation treatment after a mastectomy and what we're trying to accomplish by undertaking such a course. And I hope this will be of some help to you if you're uh, planning to see me for a consultation visit soon. So, the first point about this presentation is that what we're going to be talking about, why we think about radiation treatment in this setting and what the goals are, uh, it's all about you, your general well-being, your medical conditions, your preferences, your age. Uh, Things that aren't directly related to the cancer are going to have an impact on the decision process. And as a place to start, your journey to the mastectomy was made with your breast surgeon and possibly with your medical oncology team, but a decision was made by the entire group that removing the breast would be a good choice. And at the same time, some procedure to assess the lymph nodes typically. You may have had a sentinel node procedure or a targeted axillary dissection, or you may have had a more extensive formal axillary dissection, depending on what the findings were for the surgery. And here we're addressing people who did not have chemotherapy before their surgery. When the surgery is done, the pathologist will look at the various findings in the breast and in the lymph nodes, attention paid to the type of cancer and its details, and then importantly, how big it is and how it's distributed in the breast. There might be just one lump, or there could be many, or there could be even what's called multicentric or diffuse breast cancer, where much of the breast tissue is involved. Because in fact, some cancers don't just form a lump, they can mingle with the normal tissues and sometimes be very difficult to see how extensive they are without actually removing the breast. And of course, the lymph nodes will be looked at closely to see how many were involved and how much involvement there was. And typically, your doctors will have a report that says the cancer was this big, there was either one or more masses, there may have been some associated non-invasive cancer. There'll be a comment about the grade of the cancer, high grade being more aggressive than low. And then when the breast has been removed, a careful look to see whether there's any cancer really close or right at the surgical margins. And then the lymph nodes, how many were taken, how many were involved, the largest size of those involved nodes, whether there was cancer extending around the nodes. And then just as in the biopsy, things like the hormone receptors and HER2, which are features that give an idea about both the aggressiveness and what kind of treatments are feasible, would be looked at. Another important thing is whether the cancer had what's called lymphovascular invasion, or does the cancer invade little microscopic blood channels or tissue fluid channels within the breast. And as you might imagine, if it does, it's more likely to be able to creep around and perhaps lurk in the remaining chest wall. So just to review, the plan of care that gets us to the question, when should we consider radiation? There's been the surgery that's removed all the visible cancer, the normal breast tissue, and at least the sentinel nodes likely. And there's been an opportunity often for the medical oncologist to talk about what other approaches, medications, chemo treatments, etc., would reduce risk. And so the purpose of the radiation is, again, to act as extra insurance to try to reduce the risk of a recurrence in the treated area. And over the years, there's been a lot of debate about who benefits from radiation treatment, and the kind of considerations that are looked at are how big is the cancer? Was the skin involved? Was the cancer very close or right at the edges of the surgery? Was it in fact widespread throughout the breast? When they're spread to lymph nodes, was it minimal or was it fairly extensive? And other factors to look at are the age of the person, younger people perhaps being more at risk for these local and regional recurrences? Was it what's called triple negative, where the hormone receptors are negative and what's called the HER2 is negative as well, and the grade in that microvessel invasion? And the key point is we're looking for measuring the probability of having some microscopic cancer cells left behind. So all of those factors would be considered in making that radiation decision. But when there are sufficient risk markers for recurrence in the area, that's when one proceeds to this post-mastectomy radiation to reduce that local and regional recurrence risk. So how much does radiation reduce this risk? Well, it depends on your starting point, but a reasonable example is if, say, the risk was 15 to 20%, the radiation may reduce it to something less than 5%. And quite apart from the reduction in local and regional recurrence is the potential to reduce the probability of having breast cancer at a later time. The so-called disease-free survival can be improved by up to 10%, not necessarily, but up to 10%. The numbers, in fact, have a span. It's important to know that the post-mastectomy radiation doesn't reduce the risk to zero, depending on the nature of the cancer, whether it was more limited or what's called locally advanced, like bulky and showing a lot of involvement of the area. The risk can be reduced to as low as just 2 or 3% local or regional recurrence at 10 years, or could be as high as 20%. And just to preview, the radiation treatment is high energy X-rays that have the ability to inactivate a lot of types of cancer cells, but not all. And there is a video that I've made on how radiation works. But the basic idea is that when one is having post-mastectomy radiation, the beams pass through the chest wall and into the lymph node areas above and below the collarbone to the underarm area. And there's a small area just under the upper breastbone where there's some lymph nodes that is also treated. The key idea is that the radiation beams are set up so that any cancer cells present in that area, and of course the normal cells also are exposed and absorb the energy of the radiation beam. We rely on the idea that the cancer cells are much less able than the normal cells to repair those radiation effects so that their growth can be stopped. And here's a typical radiation machine. And in a separate video, I talk about how the treatment is planned and show exactly what areas are going to be covered in the process of going for treatment and possible side effects. And thanks a lot for your attention.